Bilal S. Mohydin. Professor Mohydin is Professor of Cardiology and Executive Director, Punjab Institute of Cardiology, and I would like to say my current boss at the moment.
Assalamu alaikum ji. Professor Khalda, Professor Khavar, Professor Bashir, it's indeed a privilege to be here and to talk on something which is close to our heart, in fact very close to the heart, because it doesn't make the heart work anymore. And as we move forward in our lives, it is these issues that need to be looked into very carefully. Before I start, may I ask you three, do you have heart failure clinics in your units, in your hospitals?
On it, starting a proper heart failure clinic.
So currently you don't?
Currently we don't.
NICVD?
Yeah, NICVD has it for last 3 years now, yes, 2 years.
For last 3 years, so that just shows the issue is still creeping up. And madam, in your center today, do we have a heart failure clinic?
In private sector, so there is no separate heart failure.
So there is such no separate heart. The reality of the matter is that heart failure is something which is there. Whether we like it or we don't like it, whether we agree with a lot of literature and data that comes in that I'm going to be saying and talking about, you see this arbitrary division that has been created in ejection fraction of 50%, 40% and below then. And when you say that person has got a normal ejection fraction and yet has got heart failure, so people are talking, what the hell are you talking about? The reality is the heart may be systolically functioning correct, but diastolically is not. Thus we see those flash pulmonary edemas coming in. Thus we see a lot of other issues which our friends from the diagnostic department keep talking about. The beauty of the situation is that the knowledge is gradually advancing. The unfortunate act behind it is that a lot of this knowledge which is advancing at a very interesting pace. Today my talk has been sponsored by Novartis Pharma, and these are my disclosures. There's no honorariums involved, there's just the travel and lodging that was involved. The reason why I say that this is interesting is because once you start involving yourself in these research and ideas, if you find anything in the research, in the pilot project, which is slightly on the negative side, you cannot talk about it. For good 10 years, that's what the contracts initially say. Unless then you start having those trials which then are talking about those negative things also. So a lot of data that actually comes in, and this motto of ours that we have, evidence-based medicine, many times the question becomes, is it evidence-based or is it evidence-biased? This heart failure business has been there for many, many years. People were living good, healthy lives earlier also. There are certain things in our lifestyle that have gone wrong. We are not exercising anymore. We're not eating right anymore. A lot of our food is adulterated. We have those questions coming in that, look, this is veggie meat which has been introduced. Things that were not supposed to be there. And they have all gradually crept in and made our life into a different style altogether. If a good lifestyle you have to follow, don't follow the lifestyle of a doctor. A terrible lifestyle which requires you to be under stress all the time. If nothing else, it's a patient's call. If nothing else, it's a family member's call. And if nothing else, it may be your own family which not be well. And since you know all those things, you start going into a heart failure yourself. And this is where the reality is. As the things are moving on, this heart failure business is going to progress. We all know from these slides that have been created that as time will progress, nearly 1 in 5 will have So just imagine for yourself that you are the age of 50 and you can't breathe comfortably. There is someone who's going to have that problem. The only point is that, like a smoker, we always believe that it's not going to be me. But when the bell rings for you, it rings hard, because then you tend to avoid it. So from a doctor's perspective, I'll request my colleagues to be very careful, because we are the world's worst patients. We are the ones who suddenly collapse. We are the ones who start committing suicides because of the burnout. These are all failures, and then the heart failure hits us like anything. And the fact is that whether you have got a preserved ejection fraction, whether you have got a midriff one, or whether you have got a low one, you are going to deteriorate. And as you can see, the deteriorations are quite same. So mortality rate at 1 year with a preserved ejection fraction is 29. For a reduced is 32, just slightly more. So you are in as big of a problem if you have had those heart failure problems. So try and find, where do you exist? When you get your echocardiograms done and you find that your patient has got a 60 ejection fraction, is that all that you need to know? Don't you need to know if he has got a mitral regurgitation, mild one, going on? Don't you want to know that what is the diastolic functions going on? And if you have got a better systems of friends working with you, then regional wall motions analysis in a better way. These are going to be the things which will help you and move in the right direction as time will progress. Heart failure, as you all know, is a waxing waning thing. You are doing reasonably okay, suddenly you have some problem and you end up in the hospital. The doctors over there give you inotropic supports, give you a diuretic therapy, and then once you start feeling well, you are back. But now, instead of climbing those 3 flights without any problem, you do get short of breath just before completing the 3rd one. And as time progresses, you start blaming everything on the fact that you have got arthritis and you can't walk up comfortably. The fact is that your body is decaying. And as your body decays, so does all the organs. That's where Bashir Hanif's calcium score really comes in, and he really helps us out and says that, look, things are not in the right side. Start looking beyond the basics. This is why it is essential that we need to do this. Otherwise, the standard statement is heard, Baba bilkul changa si, he had no problem, and then suddenly he had a cough and he died. The fact is that Baba had been gradually deteriorating. The fact is that we had not been looking into him carefully. And that is what needs to be done by all the physicians of today. We always talk of the diseases. We always talk of unfortunate problems that people have. Look at this, ladies. If you unfortunately end up with a breast cancer, your chances of surviving are far better than, God forbid, if you end up with a heart failure. Nearly 3 times better. The only thing which actually outclasses the heart failure in long term is lung cancers and lung issues. They're the only one which really outclass. That if you have it, you are gone in the next 2 to 3 years. But the rest is there. If you look up some of the old textbooks on heart failure, you'll see that they say that you lose 20% every year. 5 years, you are gone. Gradually, the medical sciences started working on it, started recognizing the whole things. This whole debate that we had earlier today about the hypertension numbers and the guidelines things, when they said that the blood pressure should be considered and they started monitoring it at 125, you are hypertensive. The idea was not as if you have to take medicine. The idea was that you should start taking precautions. If you have got a pot belly like I have, I should start doing an exercise a bit. And it seems a lot of us have these pot bellies over here. If you're not doing your regular walks, start doing them. If God Almighty is extremely kind on you and you have got the correct lipid profile, don't push your luck. If your pressures are good, that will not mean that they will remain good. So these are all the factors that you have to remember as time will progress. ESC guidelines have come up, and they have come up with all of these things, that sacubitril, valsartan. I'm going to go through these a bit at a faster pace because most of you have seen these slides many a times. And then they had this ACE inhibitors and being challenged out by sacubitril, valsartan as now the drug of choice. And do you know one thing? That if you look up all your pills, the 100 milligram pill which says 51 milligrams valsartan, this 51 milligrams is an anion, and that is why its efficacy is same as that of an 80 milligram. But a new trend that has started off is that this is not a hypertensive medication. This is still a heart failure medication. This is not being promoted on that side. So you have to remember to prescribe it and use it on that line. SGLT2 are there, and they are here to stay. Yes, tomorrow they may sound very good and they may go. But at the moment, they are here to stay, and thus in your patients, once you have got the heart rates and everything stabilized, it's probably appropriate to add this because this will help in a further better lifestyle and blood pressures monitoring further. Same is for, of course, the ARBs, and never forget the diuretics, especially in a condition when the patient has got a bit of decompensation going on. These are all the drugs which are now gradually being moving up from class 2B to class 2A. And in a few years down the road, you'll see these drugs moving into class 1. Because as the evidence is going to come up and as they are going to move into the textbooks, they will be in class 1. The ESC guidelines which have come up over here, excuse me, according to the ESC the diagnosis should include the following: symptoms and signs, ejection fractions, objective findings. The heart failure clinics, when are being run, they have to be run on these very models. You have to have these things, and the most basic thing is usually not practiced in our outpatient, and that is we never weigh our patients. If you weigh your patients, you can always have a better assessment to those swellings that the patient is complaining of. And from there you can start seeing that you need to and guide the patient that they need to get rid of 3 or 4 or 5 kgs of fluid, and that is where the body weight is going to go. These are, of course, all those algorithms that you have seen multiple times: the ACE inhibitors, the BBs, the beta blockers, the mineralocorticoids. Now the AMPA is there, and the loop diuretics. And as the things are, that whether you have got an ICD need or whether it is a CRTD need, these are all there for them. By the way, anyone have the young people sitting? Anyone has any idea what does a CRTD cost? What is the cost of this device? That we so quietly tell our patients, go and get this device. Then let the young one, you of course know the prices. Young people, do you have any idea? Well, you are always young, so for that matter, there is no problem. When these devices are placed, you are talking anything, they cost 2 million rupees at least. Now remember this, that you are so easily going to say this thing to a patient, while you are resisting the fact of the treatment cost. The treatment cost from the day 1 to day end, which is, let's say, about 20 years that a person's life you want to progress, if possible. Normally it's about 5 to 10 years that you are hoping for, but if you are able to. So if, let us say, in 20 years, you have to spend those 20 million, so it's $1 million a year that you are talking about. So 2 million, so it's 100,000 a year that you are talking about. लाख रुपया 1 साल का. इस लाख रुपए को 12 पे तकसीम कर लो, 8,000 रुपए महीने का. 8,000 रुपए को 30 दिन पे तकसीम कर लो। तो अगर तुम एक मरीज को अपने 200-300 की दवाई दे देते हो और वो दवाई उसको वो फायदा लॉन्ग टर्म में दे सकती है, तो डोंट गो इनटू दिस डायरेक्शंस। Another thing that we very quietly talk about is and tell the patient, go for a heart transplant. Do you have any idea what does a heart transplant set you back? Even in USA today, about 2,500 or 3,000 heart transplants are done, and the normal survival is about 5 years. Yes, there are people who have done better. आपको 4-5-6 करोड़ रुपए की बात कर रहे हो, एक साल किसी और मुल्क के शहर में जाके रहने की बात कर रहे हो, बिकॉज उन्होंने बायोप्सीज रन करनी है आपकी। यू आर टॉकिंग मिलियंस। सो डोंट, जैसे कि पिछले ने कहा था, डोंट ऑफर पेशेंट्स थिंग्स दैट दे कैन नॉट डू, डोंट मेक देम फील डिप्राइव्ड। व्हाट यू नीड टू डू इज टेल देम, डू दिस, स्टार्ट ऑफ नाउ, एंड दैट इज वेयर योर प्रोटेक्शन इज। अगर ये करते जाओगे तो कल को तुम बचे रहोगे, अगर ये नहीं करोगे तो फिर तुमने अपने लिए खुद ही मुसीबतें पैदा कर ली है। तो आगे से सवाल आएगा, सर क्या ये लाजमी हो जाएगा मैं बच जाऊंगा? द आंसर इज यू डोंट नो द आंसर। वो हुक्म रब्बी है, एंड यू हैव टू से दैट वेरी क्लियरली, दैट इफ यू हैव इट, बट इफ यू टेक अप द राइट पाथ, इट विल प्रोटेक्ट यू, एंड दैट इज वेयर विल मेक अ डिफरेंस। So your basic things have to be done. Your essentials have to be followed. And then of course there are the new mechanical devices that are now coming up. The left ventricular assist devices, which again set you back good about $1 million. The normal survival of a left ventricular assist is about 5 to 6 years. Yes, we have 1 or 2 of those patients who have survived even a decade. But again, there are limiting factors. These are the things which we because we have them in our knowledge bank, we very easily talk about them. But the fact is that it is your basic medication and the corrections of life that have to be done. And that is where the physician's role as a human being comes in. So let us not create patients for others. Let's do the basics for our own people. Of course, the basic treatment is the ACE inhibitors, the beta blockers, the MRAs, and now the SGLT2s, and in case of crisis, you go for the diuretics. Make sure that out of the 100,000 patients that you're seeing, you don't need to push any further down the road. And it can be done if your hospitals have those heart failure clinics. I'm totally ashamed of the fact that I come from an institute now, that I'm leading now, and we don't have a heart failure clinic over there. While a friend of mine in Sialkot, he has a heart failure clinic, and it's not even an interventional center. The basic thing is that we are not paying attention to what needs to be done. We are paying attention. You are not a cardiologist if you do not know how to hold a wire. You are a cardiologist actually if you know how to look after a patient. Wiring, these things are something totally different. Your focus for tomorrow should be on that direction, which makes you a better human being, a better doctor at the end of the day.
There are 1 minute left.
खुदा के वास्ते अभी तो स्लाइड मैंने दूसरी भी नहीं की. Anyway, so I'll rush it out now. So ANI is something recommended in de novo, etc. And acute heart failure is there. These are the 22 guidelines which came out. This, of course, is the validated guidelines which actually were there to be looked into. Of course, the paradigm heart failure trial came out, and most of you have already seen it when these trials were being done. And they had that run-in period with enalapril, sacubitril, and then they had those two groups divided, and they showed that the primary outcome was 20% reduction in CV death, 20% reduction in CV mortality, and 21% in hospitalization. Do you know the reason why we are talking of these hospitalization costs? Go to your hospital and do a basic maths. The salaries that you are paying and the utility bills you are paying, and divide that with the number of beds you have. That is the basic cost of treatment that you are giving. Currently, that cost in our country is anything between 5 to 10,000 rupees in a government hospital. This is the amount the government is spending on every patient every day, and the Branula is not even in yet. So these are the facts that you need to know. That is why they don't want the patients to come into the hospitals. That is why they need to have that reductions going on. This, of course, is a slide that you have seen that your quality of life improved a lot in your personal lives and in every way. The Pioneer Heart Study trial was exceptionally good because it actually had a crossover also between the enalapril and sacubitril, and then it showed over here that you made a big difference between the two. Enalapril was taken up as the drug of choice because initially it showed the best improvement in the heart failure trials that were done earlier. And over here they showed that a difference. But the beauty fact came later on when at the 8th week they did a crossover that those who were on enalapril were given sacubitril valsartan, and even they started improving a lot. Paragon trial is another one. 2 minutes, okay. Paragon trial is another one, and that also goes on from there. And over there the trial analysis was that based on these were the findings, the Paragon heart failure narrowly missed the primary ones. The overall safety profile was similar to that of Paradigm, and based on previous trials, the potential benefit showed that the patient with EF below the median 57% had biological possibilities of improvement. Ejection fraction was there, and this basically showed that if the slide shows basically that if your ejection fraction is really down 15-20%, probably it's not going to make much of a difference. But if your ejection fraction is good, 35%, start prescribing it, and probably at around 60%, it will not make much of a difference in the patient's life. But again, you have to find out why did the patient have a heart failure with an ejection fraction first. The European Society of Cardiology guidelines advocate the implementations of nurse-led heart failure, and this is something which is extremely essential. So if you have got those heart failure clinics, get your nurses trained into it, and they have shown a definite benefit about it, and the cost benefit, 25% was seen over there. And if you look at this graph, basically, the study done in Lorraine in France, that the heart failures really improved a lot. So basically what they were doing was that things like they're looking after the patients, monitoring their heart rates, getting the chests cleaned out all the time, and making things that the basics were right. So if you do your basics right, I hope that is going to the place. And let us hope that we all can go ahead back to our units and set up our heart failure clinics. And thank you, sir.